I'd like to welcome you to a presentation I'm giving. It's Simon McDonald here. I'm the founder of Triodent and the inventor of most of the Triodent products. Not all of them, but most of them. And we're going to go through some advanced techniques for Class 2 composites. I'll try and say composites. In my language we say composites, but we'll go with composites. Okay. First case I'm going to show is a simple DO. It is this cavity here, and first thing I want to show you there is we put the rubber dam on and a pink wedge was used. I tend to use the largest wedge I can get it in there. You get better adaptation of the matrix. One important feature of our system is that a wedge is primarily there to adapt the matrix to the tooth, not to separate. The spring is a very, very strong spring and an excellent separator, and you don't need a wooden wedge or a bit of timber, as somebody said, to use like a tent peg and whack it in there. The spring will do all of that separation for you. Now, one thing is going on here is that I've put the rubber dam on first, and then I've put the wedge in. And there's a number of reasons for doing that. A little note is with that particular type of silicon-based rubber dam, or any rubber dam, it's a good idea to put some kind of lubricant on the wedge, some KY jelly or something, just to slide it in so it doesn't slide back out again. Now, the reason for wedging, pre-wedging, before you cut the cavity, is that a big problem with Class 2 composites is that the contact point ends up too near the marginal ridge. And one of the reasons that happens, or there's a number of reasons that happens, but one of them is that if you really want that wedge to be as far in an apical position as you can get it, so if you put the wedge through before you cut the cavity, it is forced to go under the existing contact point, and that compresses the gingival tissues, which are pushing in a coronal direction, and that contact point counteracts that and compresses the gingival col and the gingival papillae and keep it down there. And another reason for putting it in there is that when you're cutting the cavity and you're working on the proximal floor, you don't rip the rubber dam. I see a lot of slides showing great rubber dam. It's all been put on there, but the rubber between the interproximal area has been ripped to shreds. And if there's one place you need good moisture control, it's there. Now, there's another reason why it's a very good idea to put a wedge in before you start, and that is it's not very common, but sometimes what happens is if you don't do that, you get to the point where you've cut your cavity, you put the matrix in, and then you put your wedge in. You sometimes get a little tag of gingival tissue that's got on the wrong side of the matrix, and when you go and inspect, see if everything's okay, you see this little tag of gingival tissue. Now, of course, that never happens, does it? But we all know that that's one of those things we just carry on. What people do is they pick up a probe and they just scrape it and wipe it off on a cotton cloth and carry on. But I don't really think that's very good dentistry, because first, what's happened is that gingival tag has a thickness, and it's going to displace the matrix away from the tooth. So whatever you do, you've got potential for a ledge to form. And then the second problem is, how do you know it's not going to seep? You've got living tissue there, and if there's one place you don't want seepage, it's right on that margin there. That bottom of the proximal box is the place where secondary caries is most likely to occur, and I believe the main reason that occurs is a bonding failure right there. Now, there's another thing on this slide which is of interest. I'm just going to draw. Can I just draw right there? Now, that little piece of enamel there. A lot of people will say, "Oh, I don't want to run a burr through there. I'd rather try and keep that if I can, but I can't get my matrix in." And I think my easiest solution is you just get a simple polishing strip, and you run that polishing strip and slide backwards and forwards. It takes hardly any time at all, and you remove just enough enamel for the matrix. It's only 30 microns thick. You don't have to take much away. Now in the next slide we've got our matrix in. An important point about the Triadent brand of matrices is that there's a tab, and the tab can be folded. Now what we do here is one way to, in this particular case, the tab would have been folded in the other direction, because I would have come in obviously from the front of the mouth, and what I do is I bend the matrix so that it's vertical, contra angle relative to the pin tweezers, so that when I place it into the mouth, all I have to do is drop it in a vertical direction straight in. Many other systems you have to do all sorts of contortions and acrobatics to try and get the matrix in the right place. Now another problem people have is that if they do it the other way, not the way that I recommend, but if you put the matrix in first and then you put the wedge in, sometimes what happens is the wedge pushes the matrix out the other side. That used to drive me insane. It was so frustrating, particularly in a very awkward position. And without that tab, you've got no way to hold that matrix. So the trick here is you fold that tab over onto the neighbouring tooth so that it's sitting on the marginal ridge, and put your finger onto that tab and press down firmly. Now you've got hold of that matrix, it can't move. And then with the other hand you slide the wedge in. Now some people might say, well, if I do it the way you just said, where you put the wedge in first and then you put the matrix in, they say, I'm not going to be able to get my matrix between the tooth and the wedge. Well, strangely enough, I find 8 out of 10 times the matrix just slides straight in. Now if it does stop, there's a simple trick, which is again to put your finger on that tab and put some vertical pressure, and then pull that wedge out very quickly. Just slide it out and back in again. In the meantime, you just kept that vertical pressure on that matrix, and it just drops in. And when you do that, you've completely eliminated the possibility of getting a gingival tag in the proximal box. Here's a shot showing the matrix in place and a yellow ring. Now the yellow ring's called a narrow ring. When we were designing this product, we put a lot of effort into working out what was the optimum force required to separate the teeth. And I had noticed that, particularly on lower premolars, many of the sectional matrix rings were very loose, just dangling there. And on a bigger tooth, a big molar, they'd be quite tight. Now, if you think about it, and Hooke's law says that the force is proportional to the extension of a spring, and that makes perfect sense. The more you open up a spring, the more force you've got to apply to that spring to separate it. So if you apply that to dentistry, well, if you put a spring onto a little tooth, then you've hardly separated it at all, and you've got hardly any force. And if you put it on a great big molar, you might have increased the separation threefold, and you're going to get 3 times more force. Now here is the first. I think we've filled up with composite there, and here's a shot showing immediately following the removal of the matrix. A tip about removing the matrix is that you've got to debond the matrix from the composites. Many bonding agents are very good at bonding to stainless steel. The newer version of the Triadent matrix has got a non-stick PTFE coating to reduce that problem. But when you When you want to remove that matrix, it really is a good idea to use a probe or a flat plastic instrument to slide between the matrix and the tooth, and so you're peeling it off. My test is that I grab hold of the wings, and if I can rotate, if the whole matrix will rotate around the contact point, it must have debonded, and then it's usually pretty easy. I remember one fellow told me a sad story where he had he grabbed hold of one. I think he grabbed hold of the tab first, and he ripped it off. I'm sure he hadn't debonded it. He ripped off the tab, and then he grabbed hold of the buckle wing, and he ripped that off, and then did it again the third time and ripped the other side off, and then he was stuck with a small rectangle of matrix in there, and he had a hard time getting that out. So it really is very, very important to peel that off before you attempt to move it, and there's absolutely no point trying to pull it if it's not loose. There's the finished restoration. Very, very little finishing. In principle, the way I think about this is that what we're doing is creating a temporary mold. As you know, it's so much easier to manipulate the composite with instruments than it is to try and carve and trying to get in. Sometimes I have attempted to do this myself, where I've got some flash into proximally, and I only noticed it after taking the rubber dam off, and oh no, what a mess. Now I've got an MO class 2 composite in an upper first molar, and here again you can see that we pre-wedged. You can actually see some little nicks in the wedge there. Notice the rubber dam clamp I've used. I've used one that is well back and doesn't interfere with the V3 ring. It's very shallow saucer type of prep. Now on this particular one, this was a teenager with high caries rate, and when I opened up that, I saw that there was another lesion on the DO, that premolar. I had to fix it there. That was my coffee break gone. Then I got on and put the matrix on. Now there's a couple of things to show here. First, there's two wedges in there. Can you see that? There's a purple one in there and a pink one here. Very good idea. They'll slide, one will slide under the other very, very easily. Sometimes I'll even put a matrix in vertically. All sorts of tricks you can do. Now here's another one where a couple of times in my dental experience I've had difficulty getting the light into the bottom of the proximal box, and I've peeled away the matrix and the composites come away with the matrix, and that's a disaster. It usually happens just when you're running late and wrecks your day, because what are you going to do? You know, you've got some horrible choices there. You can do a bodge job, or you got to really start again. Very, very frustrating. So one way is just to peel back that matrix very, very carefully and then cure from the buccal and lingual. Here's a case. People often ask, how do you do back-to-back MODOs? And that's a bit of a challenge. Here's a radiograph, quite deep caries and a failing MO on that molar. So here again you can see rubber dam pre-wedged with a purple wedge. Definitely my preferred wedge. If why not put the biggest one you can get in? The only reason not to put the biggest one in my view, is that you can't get it in. So next shot, I think I can't remember why I removed the wedge, but I did. But you can see what a fantastic control I've got over the interproximal gingival tissues there. No bleeding, no seepage, no tatty rubber dam. Over here is a GIC fissure sealant. I started using those about 10 years ago and never looked back. You have to use air abrasion, really clean that off, and you can use GIC, and it's unbelievable. I've done thousands of them, and I think I've seen two fall off, and they were impossibly difficult to do. Unbelievably good treatment, that is. So here we go. Now, if you want to do both simultaneously, you are making life hard for yourself, and you might save a bit of time, but is it really worth it? I did it in this case, but my recommendation is you do one first, then you do the other, because it's very difficult to get two matrices in there simultaneously. The tabs tend to get in each other's way, and you can often have difficulty getting the exact position of the contact point. It can easily be too distally or too mesally, but we did it. That's immediately following the last increment, and that's showing what happens when you remove both matrices and the whole lot. Very tight contact. Even the second matrix was difficult to get out. One feature about our system is we've put a lot of effort into getting the anatomical form correct. With a regular Toffelmeier, it's so easy to get what I call a tin can restoration. You can understand what I mean, I'm sure, by a tin can restoration. Yeah, one of the problems with the tin can shaped restoration is that the contact point tends to end up very close to the occlusal plane on the marginal ridge, and then you look at it and you go, yeah, I think that's okay, and then of course you get the patient to bite together, and guess what? They bite right on your marginal ridge. So you take a little bit off, and then you check the bite with your occlusal paper, and no, it's still touching. Take a bit more off. Oh no, my contact's gone because you just removed it. That is so frustrating. Another interesting thing with the Toffelmeier is, let's imagine we put a Toffelmeier around this tooth, and we're just doing a DO. Now, we're going to have one thickness of matrix band material here. That's great. We should be able to cope with that. We can wedge it. We can put one of our wooden wedges and a mallet and whack it in there and push that tooth that way, you hope. But what the problem is that you've got a second matrix band. You've got a full band. You've got another layer of 30 to 35 micron material on this side. Now, what's happening here is that you've got no buttress. This is a buttress to that tooth. You've removed the buttress because the cavity was there. So what's this tooth do? It moves distally because you just pushed it in there. So now you wedged in here, and you kind of hope that you're pushing it back, but you just made yourself a problem because of this 35 micron 30. Okay, so now away we go. We do everything right, and we've put the composite in there. Everything's sweet. Then we take a wedge out. We remove the Toffelmeier, and then, oh no, how I got a light contact. How is that possible? I was pushing against the band with the burnisher. This is impossible. How did it happen? And of course what happened was that the tooth bounced back that way when you pull the band out from that side. So that's one of the reasons why Toffelmeiers give us such grief. Now, what I did here, just to show you, is that I turned the water off so that we could just see where I trimmed, because it left a dry powder there. And put a glaze on there, and in this particular case I think I did a pretty good job in getting the contact point right, but my preference is, even though it takes a little bit longer, is to do one then the other. Just want to show you here that that's the post-operative radiograph, and you can see very nice contours, no flash. Patient had rather poor oral hygiene, teenager, he needed to come back. Now here's a tricky case. I saw this case on Dental Town. Somebody put it up kindly, and this was a upper second molar, and what happened was he posted up the final picture, and someone else who's being very picky said, look, what about that bit there? Which is a bit, dental towns are like that. And now I went back and had a look, and the problem was caused right here. So here he got the matrix band to fit nicely against that buccal cusp, but on the lingual side or palatal side, he had a bit of a gap there. So one thing he could have done was he could have put a wedge in vertically. It's a strange idea, but if you put a purple wedge, you can just push it vertically into that slot there. Another one is a bit of plumber's tape. You can roll plumber's tape into a bead and plug it into there and push that closed, and that problem would have gone away. But yeah, so I'm going to cover this way that you can adjust the matrix, and here we go. So this is a case using Isolite instead of rubber dam. You can see that I pre-wedged, and you can see the scratch marks on the wedge. Shallow cavity, trying to keep as much of that tooth as we can. And now I've put the matrix on, and I spotted I've got a problem right here, and that is going to cause flash. And if I don't fix that now, I'll be cursing under my breath, because I'm going to be trying to fix it later, and it's very, very difficult trying to get a burr in there. You can't really see what you're doing, especially if you go and nick the gingival papillae and then it's bleeding and you can't see. So what's the solution? Is to just simple ID, just grab hold of that hole with a probe. One of those hook probes works very, very nicely, and give it a little pull. And sometimes that will slide. Other times the ring is holding it so tight that it won't move. Now if you find you're holding it so tight, what I do is I pick up the forceps in my left hand, being right-handed, and I put them back on the ring and take some of that weight off by just, I don't really remove the ring, I'm just taking the load away, so I can then pull, and that'll slide through, and then I release the ring, and then it pushes it back nice and tight. And here you can see what that did. It did exactly what I wanted to do. It closed that off. And that was what happened immediately after removal. There's still a little bit of flash there, but much better than it would have been if I had just gone ahead. Now, MOD cases. People often ask about that. Again, pre-wedged, and away we go. We tried keep those cavities very small. Very important not to cut through the middle of that. That weakens the tooth considerably. Here's a good little trick. On a smaller tooth, the wings can get in the way, and so instead of allowing those wings to come in this direction, all I did was give them a bend there and there, and push them back against that ring, and that leaves room now for the second matrix. Otherwise they're crossing over each other and getting each other's right. Very simple solution to a little problem there. And again, you can see how those matrices of the tabs have been folded over in the right direction. And now, do we want two rings on here or one? I've spent a lot of time thinking about this and trying different methods, and I prefer a simpler method, which is only one ring. And what I prefer to do is I set the whole thing up with wedges and matrices, and I build that composite marginal ridge and cure it, and then I take that ring off and I move it onto the DO. Now, why do I do that? My belief is that when you've got two on there, they're tending to work against each other. If we don't have the distal one on and we put that spring on, what's happening is that tooth is able to move in a distal direction because it's not buttressed, and we can get a nice tight contact here. Then we move that ring onto the distal, and we may not get quite such a good tight contact, but we're still going to get a very nice contact and a very good solution. Some people argue that, you've caused the tooth to move distally, but we're talking about 30 microns. It's a kind of minute movement that an orthodontist might do in a day. And if you're concerned, you can say to the patient, this might feel like a little tight, a little unusual, but if you're worried about it in a day or two, you call me up and I'll adjust it. But I think you're going to be fine. And I've done that, and no one's ever rung me to say they had a problem. Here we go, last increment of composite, and that's what it looks like. Immediately removal of the matrix and the rings, and there's a buckle shot showing good shape, good adaptation, very little finishing. And that was the final restoration. Very little work to do afterwards. Going to talk a little bit about tunnel preps. They're very tricky to do. This was a first molar. Notice all that pre-wedging, and here those two tunnel preps. I'll just go back there. One thing to note is that these wedges are a very good way to control the rubber dam further anterior. I've seen a number of dentists use them, so they not only pre-wedge in the area they're working, but they also put one further forward to trap the rubber dam so it doesn't disengage anteriorly. Now here I was able to slide the matrix in place on the mesial after I'd finished the prep, and here I have struggled a bit with the shape of that distal one, and I was convinced I had a gap there, so I wasn't very happy, and I again used that hook probe to pull it round, and that fixed that problem. So now I had very good adaptation, because obviously we want a good adaptation there, otherwise we're going to get some horrible interproximal contours. So here I etched for 15 seconds and denting for 8. Pretty difficult to do that, but if you use a very tiny probe and use a good etchant like the Ultradense etchant, you can manage it. And I'm just going to show you the final result there, and here is post-operative radiograph, and I was pretty happy with that, even though it was very difficult to do. Sometimes it's frustrating because sometimes a patient seems to think because it was a small restoration they should charge you less. It takes you twice as long to do. Now here's a great piece of dentistry, just going to show you here what you can do. And there's a class 2 composite in there somewhere, and there it is. Look at that, fantastic. Jason Smithson from the UK, if you ever get the chance to go to him, he's a fabulous dentist. And now what this is showing is how well that ring is hanging in there, and it's not collapsing in. Many other systems will not do that. They'll collapse the matrix, and you really struggling. One method, if you are concerned about, if you've got more of a cusp missing, is you put the matrix and the wedge in, and then what you do is you hold that wing of the matrix in place with a finger, if you like, and well, after you've acid etched bonded, and then you build the cusp up while you've just got light finger pressure there, and then you cure that, and now you've not got a cusp, you haven't got a missing cusp restoration, you just got a standard class 2. Yeah, that's the final picture there. Main benefit here is protection of the neighbouring tooth. We all worry that we're going to hit the neighbouring tooth, and studies show that many dentists, even when they're being watched, nick the neighbouring tooth accidentally. He's placed that wedge interproximally. Sometimes you've got to be patient. When you put the local in, and then while the local's working, obviously you've got to make sure that the papillae's numb. I usually put a bit of local anaesthetic into the papillae and get it through onto the palatal side, And then you apply pressure and wait. And you've got to wait maybe 10-20 seconds with continuous pressure while those teeth separate, and then you just push it through. If it won't go through instantly, well, doesn't mean it's not going to go through. You just got to be patient while those teeth move apart. So here he's cut the cavity and he's dinged that guard a number of times. We're saving the next door tooth. And now he's taken the guard off, leaving the original wedge in there. So now there's a big benefit there, because with those, there's another product rather similar looking, but you have to take that out and put a new wedge in. And what happens when you take it out? The gingival tissue bleed. The reason it bleeds is because you've had a tourniquet on there. You get reactive hyperemia. Even if you've got a really healthy gingival, it'll often bleed. It's just because it's been under compression for the last 5 minutes while you've been cutting the cavity. If you don't take that wedge out, you don't get any blood contamination of your cavity. You can see exactly what you're doing, and very often you can slide in that matrix, and again you don't get that problem with the gingival tag. Here's the last increment, and he did a very nice restoration. Thank you, Alfonso. Now here's another case using an MOD using the wedge guards by Graham Milicic. If you ever get to see Graham Milicic, he's a fantastic dentist. He's just a genius. Here he's placed an MO and a DO guard. Now one thing you'll see here is that this guard is a bit on the high side, and his solution is he had the handpiece in his hand, and with his diamond burr he just whopped that off. It takes 2 seconds and it's gone. Then he cut his cavity. You can see how much scratching he caused on that one. We can't see that one, but anyway, it's one thing that you find is not only don't worry about cutting the neighbouring tooth, you can cut your cavity way faster because you don't have to slow down. You know, it just absolutely makes sense. Here he's removing that guard, and he's going to remove the Mizu one. All you have to do is tug in the occlusal direction. Sometimes I have to hold that handle down with something while I tug. Often the mirror head is what I've got in my hand, and I'll put my mirror head on there while I tug on that. These pin tweezers, funny thing about these pin tweezers is they've got a crossover action, which means that they lock, well, they're closed in the natural position. Big benefit of that is that your chairside assistant can put a wedge into those pin tweezers and pass you the pin tweezers of the wedge, and you don't drop it on the floor. I don't know how many wedges I've dropped on the floor in my time, but it's a lot. And so you can, many of the Triodent products are designed with a pin and a hole, and they're designed to use this. Now when we do evaluations of our products, we get two quite different groups of dentists. One bunch say, I hate those stupid pin tweezers, I can't make them, I hate them. And the other bunch say, that's one of the best inventions ever. I use them for everything. They are fantastic. I can't drop things. They're just brilliant. And I think it's one of those things, it's a bit like you got to persevere for a couple of uses and get the hang of that. You've got to, if you want to grip, you squeeze at the front, and if you want to release, you squeeze at the back. Some guys have got a very clever mechanism whereby they just move the thumb back, and that releases and grips. So do give them a try. Once you got the hang of them, they're very, very useful. They have all sorts of other uses. One of them is to hold occlusal paper. Work fantastic for that. The pin holds it beautifully. Another one is if you're doing a surgical flap, you can grab hold of the flap with those things and you don't let go, and the pin holds it. So they're quite handy for all kinds of things. I'm sure there's people use them for all sorts of stuff that I've never thought of. So there's that guard coming out. And there he's got, Graham uses isolite a lot. I don't know what he's doing there. But anyway, he's got both he's using 2 rings. It works, but to my mind, you got more clutter in the mouth. Less things in somebody's mouth, the better, as far as I'm concerned. He's last increment of composite there. Now he's pulling that out. Sometimes you can pull it out with the tab, as long as you've released it. Now notice how Graham has left those wedges in there while he's done doing all his cleanup. That's a very good idea. You control bleeding. You're not working in a bloody field struggling to see what you're doing. He's a great guy with getting his occlusal anatomy right, and he's got a very nice case there. Now here you can see the pin tweezers were being used to bend the tab. So what I call that a contra-angle. You know, we all understand what a contra-angle handpiece. By bending that tab, it allows you to drop that matrix in the right orientation in an apical direction. It slides just straight in. Now, there was another point on that animation that makes life a lot easier. You just use your finger probably on the lingual side, or if you're on the other side of the mouth, on the buccal side, whichever side's easiest, place a finger on that wing as you disengage. Another important point is that those pin tweezers are gold. One of the arms is gold and the other one isn't, and the gold indicates that is the one that has the pin. You can get yourself in a tangle if you have those pin tweezers the other way up, because when you try and disengage from the tab, you can't get the tweezers out. You're stuck. So you must ensure that gold is above, on the top, on the occlusal side, and then when you let it go, you can get out of there. Now I'm going to talk you through how you put the ring on, and because things can go wrong at this stage, very, very important that you get a finger rest. You absolutely have to be steady with your hand. I've seen some people holding with this, because that spring's pretty strong, and their whole hand is shaking as they approach the tooth. Now, an obvious thing to do is use your other hand, rest it on, say, the incisors, and use it as a guide so that you're steady. Now, you want to move into that position very, very slowly. One thing you don't want to do is get the matrix jammed between the V of the V-ring. That happens less so with the new Supercurve because it wraps so nicely. One of the benefits of the Supercurve. But it's definitely a good idea to go very slowly, very steady, and take your time. Now, another thing you'll see in the animation is that a finger has been placed over the top. One thing that can happen is as you're just releasing the spring, it can nudge the matrix and knock it out of position. So what I do is I put my finger on the tab after I've put the ring on, but I haven't released the spring yet. I put my finger in there and I slowly release, and I'm pushing everything down. You haven't got any worry that the tines of the V-ring are going to impinge on the gingival tissues. That is impossible. And the reason that's impossible is the wedge prevents it. The tines cannot. The tines are approximating to the wedge, and they can't go any further down. So that's a very, very important step to seat the whole thing. Another thing that does is give complete stability as you remove the forceps. You keep your finger on there until you've got the forceps out of the mouth and push the whole thing down. Particularly if you've got a missing cusp and the ring hasn't got a lot to stay on. But if you do that, the ring will stay on 100% of the time. Will never jump off. Very good.